I'm the project director for Momentum Routine Immunization, Transformation, and Equity. We are a USAID-funded project that works toward a world in which all people eligible for immunization, and particularly underserved, marginalized, and vulnerable populations, are regularly reached with high-quality vaccination services to protect their children and themselves against vaccine-preventable diseases. We're happy to have the opportunity to tell you about our work to support the government of Vietnam to reach very remote populations with COVID-19 vaccine, with improved microplanning to bring services to unvaccinated populations. Before we begin, I just wanted to go over a few housekeeping tips. Please use the Q&A button at the bottom of your Zoom window to ask questions during the presentation or for any technical help that you might need. If you need to enable live transcriptioning, you can do that by navigating to your meeting controls and clicking on Show Captions or using the CC button at the bottom black bar. You can also use the chat feature to introduce yourself and share any thoughts during the presentation, but please don't use that to ask questions because we'll be monitoring the Q&A button. The questions you ask using the Q&A button are only visible to you, our presenters, and our technical support team. If your question is about technical issues, our technical team will respond to your question privately, and we'll collect all the questions for our speakers, and we'll save them for the discussion period following the presentations. This webinar is being recorded, and following today's event, you'll receive an email with a link to the recording. If there are questions that don't get answered during the Q&A session, we'll forward them to the presenters and share responses by email to all participants. We've planned over 15 minutes at the end to answer all of your questions. Before we begin, I want to invite Mr. Randolph Augustine from the Office of Health within the USAID Vietnam Mission to provide some opening remarks and set the stage for this webinar. So please.
Thank you, Grace. Thank you, colleagues. Good evening, afternoon, or morning. I'm not sure where everyone is located. But I won't be long. I, again, want to first express my pleasure of providing opening remarks and having the opportunity to share the key lessons that we've learned from the experience in Vietnam. On a personal level, having recently arrived in Vietnam and having supported similar programs in 2 countries in the last 2.5 years, it is encouraging and impressive to see what has been achieved in Vietnam, and it speaks volumes to what is possible with a stellar team on the ground, excellent leadership and commitment from the government of Vietnam, community leaders, community organizations, and communities themselves. Again, we all know that each experience is unique, but I do trust that the excellent team from Momentum will be able to distill some key lessons from the Vietnam experience that can be applicable to your various contexts and will enrich our overall knowledge as we each try to tackle these very important issues in whatever communities we work in. So again, thank you all and look forward to the discussion. Over.
Thank you very much, Mr. Augustine, for that introduction. Now I want to go ahead and introduce our 2 speakers for today's webinar. And just so you know, our speakers have joined the webinar today, but we had recorded their presentations earlier in case of technical problems. So what you'll be hearing are pre-recorded presentations. However, they will be available during the Q&A, so please be sure to put your questions in the Q&A box. So first, to introduce our 2 speakers, first I want to introduce Dr. Ham Thi Dung. Mr. Dung is the Vietnam Country Program Director for the Momentum Routine Immunization, Transformation, and Equity Project, as well as the Vaccine and Immunization Team Lead for the PATH Vietnam Country Program. He's a medical doctor with expertise in infectious disease and surveillance systems, outbreak detection and response, and control and prevention programs on a national level. Mr. Dung has more than 21 years of experience managing national-level immunization programs, where he provided both technical and managerial support. Along with the Momentum Routine Immunization and Equity Project in Vietnam, he also provides support to other immunization program activities in Vietnam, as well as Laos and Cambodia. Our second speaker will be Mr. Dao Ding Sang. Mr. Sang is the Monitoring, Evaluation, and Learning Lead for the program in Vietnam, as well as the Senior Program Officer at PATH for over 12 years. He's pioneered PATH Vietnam's work in digital health solutions and has led the technical component of these projects. Mr. Sang has been instrumental in the development of the project's microplanning tool, which allowed for health workers to accurately evaluate facility capacity and forecast COVID-19 vaccination demand, which he will be speaking more about in this presentation. So before we go ahead and play the presentation, just want to remind everyone to please type your questions to the speakers in the Q&A box.
In 2020 will identify the first case of the COVID-19 in Ho Chi Minh City in Vietnam. After that, the so-called economic situation very strongly affected by pandemic, and series of control activity were implemented, including the social distancing lockdown. In 2020, our country controlled the epidemic is very well with a total of 35 confirmed deaths for the whole year. However, in the end of the 2021, epidemic will already become very serious. And until the August of 26, 2020, the pandemic was expressed to the 63 provinces and cities in the whole country, and Vietnam already officially reported 11,396 to 1,205 cases and 43,110. July 10, 2021, government has launched the vaccination campaign for the COVID-19 vaccine. And the first dose, we exceed 80% of the total population by the April 3rd, 2022, and make the country become one of the leading countries over the world with a high rate of COVID-19 vaccination. However, we're still facing the low coverage among the high-risk populations and the people who residing in the remote and mountainous area. You look at the map here is the vaccine dose is until now is existing 250 million doses, and people who receive at least one dose is more than 90%, and people with complete initial protocol is more than 80%. And now we continue for the booster dose. The MRI funded by USAID with the goal to reduce the COVID-19 morbidity and mortality by supporting the vaccination introduction and deployment. We are focused on the vulnerable and marginalized population and those who miss today in the 5 historic mountainous provinces, namely the Điện Biên, Sơn La, Hòa Bình, Quảng Nam, and Ninh Thuận province. Those province you can see on the map in the red color, and those province was based on the government identified need. In the project, we also collaboration with the local partner, namely National Institute of Hygiene and Epidemiology, and also Pasteur Institute of Nha Trang, together with the 5 CDC in 5 provinces. We also very close collaboration with international organizations such as WHO and UNICEF to implement the project with the objective to support those API in the province on micro-planning, strategic implementation for the COVID-19 vaccine rollout, and also provide the immunization technical support, capacity building, ally closely with the government priority and protocol, including the supportive supervision. Besides that, we also conduct a series of the monitoring, evaluation, and learning. In order to implement the project, we apply the COVID-19 vaccination strategy that is focused on the mobile vaccination to reach the marginalized population. In the last mile of COVID-19 vaccination, the project is focused in the proof having the access to go to the vaccination among historic population in 5 provinces, especially the people who living in geographic remote and rural area with the transportation disruption and among the ethnic minority and also the migrant worker. Since 2021 until now, through the USAID support, the project already supported 1,318 mobile sites and to give 737,977 doses of the vaccine in 5 provinces. So you look at the graph, you can see the different target population get the different number of dose vaccine. When implement, we're facing some challenging, that is a rush terrain and limited paved roads, mean a long travel time to the health center and vaccination site. The health center also faces limited equipment and local financial and human resources, especially the language barrier for the minority group because they don't understand Vietnamese very well. MRI project adapted to mobile vaccination strategies that have been long used to provide the routine immunization in this project that includes a multi-sectoral coordination, engagement of local authority, community leader and community member, additional of new mobile site to reach priority population. So multi-sectoral coordination, including the health and non-health stakeholder. They will help to identify the appropriate local site, ensure safety efficiency, especially compliant with the MOH guideline. And the contribution from multi-sectoral actor, including the community health worker, emergency unit at the local hospital, local police, social organization, and also local people committee. It has ethnic minority leader who have fluent over the population and speak the local language. They have become the champion for the COVID-19 vaccination, and they can have to increase the demand. The teacher, farmer, the local store owner, women union also important. They are rescued and quickly trained to support for the vaccination. In the vaccination section, including the welcome, registration, verifying the vaccination subject, data entry and translation. Look at the picture here. You can see the village youth union who support for the vaccination and translation for the Hmong ethnic group. Additional of new mobile vaccination site in project, we are using the existing routine immunization site in the cultural house. Besides that, we also use a new site such as the kindergarten and a periodical school and community hamlet gathering hall. And new site also located with community inputs to reach a specific priority population such as the migrant worker, health and non-health sector, and community leader. It's become very critical to coordinating on-site logistics and generating community buy-in and demand. Rescue the community volunteer to assist the essential task for the vaccination. That will be a good solution in setting with human resource shortage. Multi-sectoral coordination and mechanism, and trained non-health staff, and newly estimate and established the mobile vaccination site can be used for the routine immunization and supplemental immunization activity. One of our lessons learned, that is the education sector engagement to reach the children. The first dose was administered for the children on the April 14, 2022, and then until now is appropriate about 3.6 million children already get infected with COVID virus. Regarding the MOH guideline, the children from 5 to 11 just vaccinated with the 2 kinds of vaccine only, the Moderna and Pfizer, while the children from 12 to 17 years old got only a Pfizer vaccine. One the guideline that said that if the children who have gotten the COVID-19 infection, they have to wait for 3 months. We're facing some challenges such as reduce the COVID-19 prevalence and restriction, as well as the high COVID-19 vaccination coverage in Vietnam. So that is lead to reduce the demand for vaccination, and we also see the increase of vaccine hesitancy to work for the COVID-19 vaccination for children, because some children already get infected and recover, so they don't want to get the vaccine again by the parent, and we're concerned about the long-term side effect myths that have been spreading the community regard the memory loss and potential damage or impairment on the reproductive health and fertility of the child, and so on. So another challenge is the guideline on children vaccination was unclear for example, the children in the transition between age group and mixed mass vaccine, and requirement for waiting time for the infected children. That leads to confusion for the healthcare worker and parent. So the one strategy we are focused on is continue and closely coordinate with the education sector, especially with local people committee and the COVID-19 vaccination steering committee, facilitate coordination between health and education department. The teacher in the school have a consolidated list of the children in the target age group, and when the school return into the mobile vaccination site, you can gather all the children there and vaccinated for the short time. Vaccination section also integrate into the after the school activity. All the teacher, principal should promote and encourage the parent for vaccination.
Dr. Zong, we're having trouble hearing you if you're speaking. Okay, I think I'm going to jump in here. With that presentation, we wanted to, given the focus on hard to reach populations, we wanted to see, get inputs from our from our participants about the strategies that you may have used to reach hard to reach populations. So please feel free to use this QR code or the link in the chat or the QR code in order to provide inputs to this question. Or you can go to menti.com and use the code that's shown here.
Thank Grace. Yes.
Great. Glad you have your audio back. I'll hand it back to you.
Yeah, thank you. So you look at the screen now, and thank you very much for the participation in the poll question. I would like to take a few minutes to go over some of the answer that you can see on the screen. The answer is the mobile vaccination van. Yes, I think that also the good solutions. But in our country, the mobile vaccination van is not applied for the COVID-19 vaccination. We all use the land the place like control hall or the school bay or community bay that is set up the mobile vaccination site. Another one is a micro planning and mobile vaccination team. Yes, that is exactly what we also do that strategy in Vietnam. The next answer is older population with limited mobility. Yes, this is also the high-risk population or vulnerable population in Vietnam. That is also target population in the Momentum project. Another one answer is urban poor. Yeah, in our project, we are focused on the rural and mountainous area. That is more like a rural area rather than the urban or outskirts of the city. So it is not because we are select 5 mountainous and remote area, and in that province you just selected only the village categorized by government, that is a poor and difficult and remote area in the project. So the next answer is children in the slum settlement or unrecognized housing community. Yes, in our target population is also including the children, because the government and ministerial guideline is allowed to vaccinate for children from 5 and under 12, and of course the adolescent above the 12 years old. However, that children is include all children, even children in the school or in the in the selected commune and selected province. So the own children, including children in the slum settlement, also included in our project. The last answer here is out of school children, zero children, and children working in informal sector. Yes, we also have a strategy to reach the school out of the children out of the school, because we have a 10% of children did not attend the school. So we also, that's the reason why I have to do the review, the need of the children, especially work with the relief health volunteer to identify the children who are not attend the school, and then we advocate their parents and bring the children to the mobile vaccination site and vaccinate COVID-19 for them. And of course, we also try to get zero-dose children. That's also our aim of the project. Thank you again for the participant, and now back over to Grace.
Yes, I think we're going to go on to Mr. Sang's presentation now.
Hello, everyone. On behalf of the team, I would like to share with you our lesson learned on micro-planning tool development and implementation in Vietnam to support COVID-19 vaccination campaign. In Vietnam, MOH implemented COVID-19 vaccination system from the beginning of the campaign in March 2021. However, due to the constraint of time and guidance on the vaccination change frequently, so the system had limitations and how to work at the different levels, had some challenge in making plans for COVID-19 vaccination as well as the report. The challenge the facility have is the vaccine arrival without much notice and vaccine expiration date. Health workers do not have a good quality data to make an effective plan. Commune and district health staff did not have a way to estimate the number of stocks and resources needed to implement the COVID-19 vaccination, especially when the facility received different types of the vaccine with short shelf life and different expiration date. The lack of the standardized planning format for all facility at own level is also the challenge. Each facilities, they have their own template for planning, and the plan is very simple and in general. In response to the challenge, the Momentum team, in collaboration with national EPI and regional EPI, to develop an Excel-based micro-planning tool. The tools were developed based on the need of how the worker found in landscape assessment and adapted with the WHO guidelines. The prototype of the tool was developed and piloted in Sơn province to get more feedback for improvements, and the team finalized the tool before rolling out to the On-File project province. The tool is a pre-programmed with the simple function of the Microsoft Excel to help how the worker at levels to calculate automatically based on their input, and how the workers input information required into the tool, such as the number of target populations by group, the quantity and types of the refrigerator available at their facility, update vaccination progress, and number of the vaccination sites they conducted in a day, and expiration date recess. How the workers who are in charge of creating the vaccination plan using micro-planning tool to estimate the need for the whole campaign. In Vietnam, quantity and types of vaccine depends on the allocation from higher level. Each time the vaccine arrives, the facility has to make a plan. They update their vaccination progress by age group with number of clients vaccinated, by type vaccine, and by sort based on their daily data report. They enter quantity and types of vaccine coming. Based on the input data, the tool advises necessary information for how the worker, like number of stock, number of health worker, number of volunteer, and coaching the capacity needed for the campaign. The facility submit plan to the district level. Based on the plan from the own facility in the district manager uses the tool to make a plan for district level. They use that to allocate vaccine properly, as well as the assign staff to provide technical support for facility. Managers also understand well about the need of the capacity building, so they design and conduct a series trainings to fit with the need from the facility level. At the beginning of the implementation of the tool, there was resistance from the health care worker. They did not want to learn and apply the new tool, so we have to work closely with the regional EPI and the provincial CDC to provide coaching and supportive supervision to encourage them to use the tool. The micro-planning tool to bring some benefits like increase the accuracy of local level needs forecasting and planning, reduce the vaccine wastage by allowing for appropriate reallocation of access vaccine to other commune or districts with the vaccine shortage, save time for commune level staff, provide district and province level staff with a standardized tool with a high level buy-in from the national and local government agency. It also have the opportunity based on the COVID-19 vaccination. The tool can be adapted for routine immunization, particularly for catch-up vaccination for the children who missed the vaccination due to the COVID-19 outbreak. And it could be integrated with the other health activity. With support from the project, 100% of the commune in Sơn La, Điện Biên, and Hòa Bình uses the micro-planning tool, and 1,500 plans created or adjusted based on the tool developed by the project. Some lessons learned: the micro-planning tool provides the facility leader manager at a different level in decision-making and forecasting the resource for COVID-19 vaccination. Investing in the standardized tool with high level of the buy-in from the own level of the health system across geographic area improves the efficiency and coordination. With benefits the tool bring, the CDC were committed to use and issue letters to on the level to use these tools developed by the project for data capturing and making the micro-planning. Approach uses the digital solution as a most impactful and helpful. So when solutions are analyzed carefully, the need of the health worker in different levels to fit for the purpose and the local context. Providing the training and mentorship or technical support through the supportive supervision on the use of the digital tools is critical to get success and also the sustainability.
Thank you, Sam, for the presentation. Now we go to the poll questions. The question is, what are some adaptations or the improvement that you or others have made to data planning or reporting system during the COVID-19? This is a QR code. You can use your mobile phone to use the QR code to get the question and answer, or you can go to the website www.menti.com to get the question and answer. So we have 2 minutes to go before we go to review all your answer. So I got some answer here already. So 30 seconds more so we can go to the answer. So now, thank you very much for your participation in the poll questions. I would like to take a minute to go over some of the answers that I'm seeing on the screen now. The answer is the capacity building of the health worker. Yes. So in order to improve for data planning and also make the micro planning, so we have to do the series of the training for the micro planning. Especially for health worker at a different level, focus on the province and district level. They are the more important to make feasible the COVID-19 vaccination section in the community. Second answer is have to expand to include the wider range of the age group. Yes, you are correct, because the micro planning, when we have a different target population, you know, the government try to expand the target population for COVID-19 vaccination. So as at the beginning, we just focus on the older adults greater than 18 years old, and then we expand to the 12 under 18 years old, and then 5 to under 12 years old. So the micro planning tool also have to update it and also have to cover wider range of the age group. And in the future, for the children from 6 months to under 5 years old, yes, also have to include in the micro planning tool. The next answer is a frequent review meeting to review and use data. Yes, you are correct. We have a very frequent review meeting with different level, especially with provincial level and district level. During the review meeting, we invite also the NAPI and also Northern EPI office and expert to join, and they also update the current and almost up-to-date regulation from Ministry of Health. During the review meeting, we also discussed about how to implement the micro planning and how to conduct the micro planning in Google and how to use data. Yes, that's also the good answer. The last one is linking the community health worker with the facility to help find the high risk population as a digital map alone is not sufficient to find individuals. We identify the high risk population at the beginning. However, when we do the vaccination, it's the comprehensive population. It's a whole population. So everyone is coming, even in the high risk area and also the unhigh risk area. You know that at the beginning we have a very limited number of vaccines. That's the reason why I have to give the priority for some population and the high risk population only, especially for health worker, for the elderly, and also for the people at the high risk population. However, after that, when we have a lot of vaccine arrival, and a whole population will be a target for the campaign. So thank you very much again for the participation, and now I will back over to the Grace again. Grace.
Thank you very much, Dr. Dong and Mr. Sang, for those excellent presentations. And thank you to everyone in the audience for the participation in those polls. It was great to hear about how the Vietnam team worked to address the special challenges around reaching children and the most remote populations for COVID-19 vaccination, and also to hear about all the work to support microplanning, which is critical to be sure that the vaccines with short expirations are put to good use. I want to encourage everyone to put any questions in the Q&A box. We have 2 questions there that are great questions, and I want to ask our panelists to answer them. And I will read them both out, and then Dr. Dong and Mr. Sang, please jump in to respond for everyone. So the first is, can you please describe how elderly populations will be prioritized and reached for future COVID-19 vaccination as focus shifts back to routine immunization and children? And then the second question is, what specific lessons did the project team learn regarding recruiting health workers to administer the vaccines? So Dr. Dong, do you want to answer those?
Yes, thank you, Grace. So I think this is a very interesting question, and also that is also the big topic discussed in our country at the moment. The first question is about the elderly population and how is the prioritized. So, the elderly population is at the beginning of the vaccination campaign is one of the priority population, as I just mentioned a few minutes ago. And in the community, elderly population was identified by commune health center. So the healthcare staff in the commune health center, they have a lead of the elderly, and they make the lead, they make the schedule for vaccination, and then they invite them for the vaccination side. However, in some areas, especially for our project area, the elderly people is usually they don't have a chance to join the vaccination section because it's very far, and they don't have a transportation or a vehicle, or they cannot go by themselves to the vaccination side for the frequent vaccination. So they usually they are lower coverage of the vaccine when we go to those project province. That's the reason why the project also collaborate with the local authorities, especially with the different union, such as the women union, farmer union, and also we have a village health volunteer. In every health care center, in every commune, they were supported to identify the elderly and support them, make the lead of those and organize some specific vaccination section inside the community, such as they organize in the cultural house or the one house of the healthcare worker, and they very closely with the elderly population, and then they invite them to go to come for vaccination. We also organize a team go to directly to the house of the elderly, but not much because it's very hard work and very take time to do that. So that's the reason why the mobile team go to the household usually at the end of the X campaign, and then we vaccinated for elderly. And why we do the mobile side and mobile team, because the mobile team is not usually take a lot of the participation and resources, such as we have to bring a lot of equipment and move the vaccine along with the mobile team, and also have a travel. We have to pay for the travel fee. So that's the reason why the local authority and current healthcare system don't have enough financial resource to fund it for the mobile side. That's the reason why our project is contributed partly and support for the mobile side, and that's the reason why we can vaccinate it for the elderly in the specific area. The second question, as you also mentioned about routine, how to shift back to the routine immunization and infant. I think we also already discussed about how to shift back to the routine immunization. The government also considers the COVID-19 as a routine vaccination and can reimburse for that. However, that is still because the COVID-19 is still considered a pandemic, meaning the government have to take care of it, and the vaccination should be separate from the routine immunization at the moment. That's the reason why I think in Vietnam now we not just have any official decision to shift back to the routine immunization. We still conduct the immunization for COVID-19 as a campaign separately from others. The next question is what specific lesson did the project learn regarding the recruiting the health worker? You know, the health worker, we are mobilized on the health worker in the system to support for the vaccination. So that is the health worker existing health worker network. And then if we don't have enough healthcare worker, we can mobilize some of the healthcare worker in the hospital. So you know, a number of the healthcare worker in the hospital already you know, collaborate with us and support for mobilization. Beside that, we also recruiting some non-health workers, such as the youth union and the women union, as all the village health volunteer also join for the outreach vaccination. Thank you. Back to the Gray.
Thank you. We have another question that came through. That's an excellent question, and I think others would be interested too. What is the impact of rumor and misinformation while implementing COVID-19 vaccination? How was the situation addressed in order to build trust and create demand?
Yes, I think we have a very big problem at the beginning of the COVID-19 vaccination. Back to 2021, we have a first arrival of the vaccine around June of 2021, and then in July, the government is starting the big hit campaign for the COVID-19 vaccination in the country. At that time, you know, we don't facing a lot of the number of case of COVID-19 in Vietnam. That's the reason why people still are scaring to get the vaccine. They still worry about safety and the effectiveness of the vaccine. So that time, yeah, we have a very strong impact of rumor and misinformation. A lot of very bad story about vaccine and how to get the vaccine, and a lot of the story around that. People, you know, talking about the rumor and misinformation rather than the truth. That's the reason why, you know, the government also have one strategy for advocacy for the COVID-19 in collaboration with WHO and UNICEF. So we have a series of the material, the IEC material, to educate for the population, different population, for adult and for the school children, and also for the parent of the children. And in our project, we also organize very big the forum, the panel discussion. We invite the leading expert in the country. One is come from municipal, one come from NEPI, and one from the local. And one doctor from the hospital also joined with us, and we also invited one expert from WHO, but finally he cannot join it. So that panel discussion is also one forum, invite about more than 3,000 people to join, and we talk about why we have to implement the COVID-19 vaccination and how to do that, and the role of the healthcare worker for the COVID-19 vaccination. So when even in the panel discussion, we can also identify that some of the healthcare workers still scared and suspect about the safety of the vaccine and effectiveness of vaccine. And even for the children, especially for children from 5 under 12. So by that way, we have a voice from the different expert, leading expert, to explain step, X topic by topic, X issue by issue. And then by that way, they understand and they have a very strong collaboration later on. Well, we do the same thing for the community. We have a lot of forum from government and also from NEPI, where they implement the COVID-19 vaccination campaign in order to address a lot of the problem from community and create a demand for community. Over.
Thank you for that excellent answer. I wanted to jump in with a question of my own, and building on this question about trust and misinformation. I know occasionally, even for routine immunization, there are periods where there may be some mistrust of the vaccine and questions about the safety. Can you say a little bit both on the question of vaccine safety and trust, as well as some of the work that's been done to reach very remote or migrant populations? Are there lessons for routine immunization based on this work?
Yes, I think vaccine safety is very hot topic. At the beginning of our project, and also at the beginning of the campaign in the countries, because when we implement the COVID-19 vaccination for the very big population, big ever, because before we just vaccinate for the children or for something inside, for some vaccination only, but for COVID-19 we are doing for the whole population. And all they have a different age group, different level of knowledge and understanding about about vaccine. So the vaccine safety is the hot topic many people discuss around. That's the reason why you have to provide a lot of. We not just say this is vaccine is safety. We have to provide the evidence. So that's the reason why a lot of forum, even in the newspaper and in the social media, we have to provide the figure, the evidence from the scientific paper, and also from we also have to analyze the side effect. You can show that the side effect rate is very low to compare to the routine immunization vaccination, and also we never have a comprehensive and no side effect vaccine ever. So we have to face some risky, but the risky is very minimum, and the risky compared to benefit is much huger. Another one is the voice from the WHO and UNICEF play very important role for the vaccine safety. In some case, in Vietnam, we facing some side effect and even deaths related to after the vaccination. And the WHO is jumping in and provide a lot of explanation and evidence to prove that some case is not related to vaccine. We can give the evidence to prove that's evident. That's the reason why that is a strategy we apply in Vietnam. We have to collaborate with with WHO, with international organization. Beside that, we provide the evidence for them in order to ensure the vaccine safety and trust. Over.
Thank you for that. Is there any more you want to add related to, being able to reach migrant populations? Are there any lessons for routine immunization in that regard? Dr. Dung, can you, if you're speaking, we can't hear you.
Can you repeat the question again? I'm sorry, I missed your question.
Yes, the question was, are there any lessons around the work that MRITE did in Vietnam to reach migrant populations that could be useful for routine immunization?
Yes, okay. That also interesting question, because when we conduct implement the project in 5 provinces, we have one province have a very big problem with migrations. That's the reason why, when we support them and finally they report the vaccine coverage is more than 100%. Sometimes it's the highest number is 126%. So that's very strange, very outrage. So we are in the Ninh Thuận province, in the south of Vietnam. So we have to do the supervision immediately after we get that figure and go to the Ninh Thuận province, work with CDC, and we sit down to analyze the data with them. So finally, at the beginning, they support the lead of the subject, that is the local people. But when they implement the vaccination campaign, they vaccinated for a lot of people is not in the list. That is a migrant worker, because that is the industrial zone. A lot of workers from other provinces come there to work for solar energy and also for the wind power plant there, because they have a very big wind power plant in Ninh Thuận. A lot of migrant workers come there to work. So when they conduct the COVID-19 vaccine, they vaccinate for everyone. They don't say, okay, you are local or you are migrant. But when they go to the vaccination site, they vaccinate it all for them. That's the reason why they are reported the number of the people get the COVID-19 vaccine more than the denominator. That's the reason why they get is more than 120, more than 100%. So for the migrant, I think that is a very good experience for it. Is first thing, we have to identify the migrant at first. For Ninh Thuận, they don't do the survey and review the subject in the local very well at the beginning. That's the reason why they're facing some problem with vaccination, because they are plan for the vaccine is less than the number of demand. That's the reason why they get some problem. So one lesson learned from that is have to review all the subject, even the migrant population should be included. That is at the beginning. The second one is when we vaccinated for the migrant, we have to ad hoc register or ad hoc reporting for the system. So because in our system, the online system, we call the COVID-19 vaccine. We have a website for that, and people, when they vaccinated, they entry the data on the website. However, the website is not linking from this province to another province. So that is one limitation. However, we can, but the one experience is we have to report the number of case who come from other province or come from other place to come to the Ninh Thuận province to vaccinate it, to report back to that to the original province they come from. So by that way, we will not overlapping reporting the data. So if the Ninh Thuận still reporting, they will get more than 100%. But if that migrant worker come from province A, and province A is, when they report, the coverage is so low because they are lacking of that person, even that person in the province A. However, that worker have get vaccine in the Ninh Thuận province. So that is a true experience, lesson learned from migrant worker. We can learning from Vietnam. Thank you.
Thank you for that. We're near the end of time, and so that will be our last question. I want to thank Dr. Zong and Mr. Sam again for those excellent presentations, and thank you to all the participants for the great questions too. We now have a few minutes. I'm going to hand it over to Erin O'Riordan from our USAID AOR team to provide some closing remarks.
Hi, everyone, and thank you, Grace. Thank you all for your questions and engagement in today's webinar. While the MRight project had a time-limited engagement in Vietnam, it made important contributions to the COVID-19 vaccination campaign across 5 provinces. With its rapid activities and innovative interventions, the project reached underserved and priority populations with COVID-19 vaccines and provided a model that the national and regional EPI programs can apply and adapt for other provinces. Many of the project's contributions, including strengthened health worker capacity through training and supportive supervision, the development of scale and microplanning tools, and relationship building and coordination across administrative levels, will continue to benefit routine immunization beyond the project's end. Together, these contributions have increased immunization service delivery and resources, forecasting expertise at local levels while building trust between key stakeholders that can be used for immunization more broadly, as well as other health interventions. We hope that the lessons learned from this work can be useful for other countries, and thank you again for your time and engagement. Back to you, Grace.
Thanks very much, Erin. Before we drop off, I wanted to ask everyone to take 2 minutes of your time to provide feedback on our webinar. You can use the link here, the QR code on the screen, or I think there's a link in the chat in order to provide feedback. It will only take 1 or 2 minutes and is really valuable to us. In the next few days, you'll be receiving an email with a link to today's recording. So thank you very much for your participation, and thank you to our speakers from USAID as well.